Good morning, everyone. I see some are still entering the room, but I'm going to go ahead and get started because it is 10 o'clock. And I want to welcome you to our 5th installment of this year's Nutrition Symposium with the Nutrition Consortium at the University of South Carolina. And it is my pleasure today to welcome our practice panel to share their insights and their thoughts. And I will have one quick announcement before I introduce and turn it over to our moderator today. So next week is our final webinar session, 10 a.m. webinar session. It will be led by the Nutrition Student Research Group, and our poster winners will be announced, and they will be presenting on their work they had submitted as a poster. They'll present a longer presentation as well as some other topics. So I encourage you to join if you would like to see how the students are doing and what sort of work they've been engaged in over the last few months. It is my pleasure to introduce Abilene Cordova, who will lead our session today. And I'm going to turn it over to you, Abby, and mute myself.
Okay, great. Thanks for attending. I'm excited to help facilitate this panel discussion with some practitioners who dispense nutrition information. So we have with us today Kristin Coggin, who is the Director of Performance Nutrition here at U of SC. Brooke Brittain, who is a Program Manager for Public Health Nutrition Outreach at Clemson. Nancy Lintner, the Diabetes Care Education Specialist. Olivia Sullivan, who is a dietitian with the University of South Carolina Student Health Services. And Jim Cook, who is an obstetrician gynecologist who leads the centering pregnancy groups here in Columbia. So with that, I would like for each of the panelists to just give a brief background about you and what you do for our group to become acquainted with you. So can we start with Kristin Coggin?
Hi everyone, I'm Kristin Coggin. I'm the Director of Performance Nutrition and the Director of Football Nutrition here at the University of South Carolina. This is my 4th year here, and McKinney was one of my first students. But a little about me is I oversee all of the dietitians, but overseeing the nutrition for all student athletes at the university. So on my staff, we have 3 other full-time dietitians, but we plan all their meals on the daily. We provide work with the dining hall. You know, our dining hall is in-house for athletics, write the menus for that, counsel individual athletes on their day-to-day nutrition, performance nutrition, plan all the meals at home, plan all the meals on the road. We travel with the team. Right now with COVID, it looks a little different than it used to, but it's definitely brought some new challenges, and we kind of use everyone in the mix. So that's kind of a little bit of a rundown, but cook with them, take them to the grocery stores. There's a number of things, but it's a fun profession to be in with them.
Great, thank you. And then can we hear from Brooke now?
All right, morning everybody. All right, I'm gonna set my timer. I've already warned these ladies I get paid to talk for a living, so I'm gonna try to cut myself off too. So a little bit about me. My undergrad background is in health promotion. I did go to Coastal Carolina. In it, I took a nutrition course, and that was what spurred my interest for the rest of my career in life. So I ended up getting a master's in food and nutrition from Florida State. I am a registered and licensed dietitian. I am a certified health education specialist and a certified lactation counselor. People laugh and say I got alphabet soup behind my name. I'm like, it's just a lot of debt. That's all it is. It's just a lot of debt. But the start of my career, I have over 15 years in community nutrition. That is my specialty and focus area. I started with WIC when I was still down in Florida. So I did that for a couple years. Great entry-level position. You learn so many different skills, being introduced to so many different people, from all kinds of walks of life. Fantastic program. There's such a need out there. We assessed, nutrition status so it's women, infant, and children. So babies and kids up to 5, and then women that are pregnant, postpartum, or breastfeeding. So assessing their status and kind of prescribing a care plan. And then from there, a job opportunity, so I was still down in Florida, came up with DHEC, with our Department of Health, with the SNAP education program. And I just spent 13 years with them, and I loved my job, super fun. I traveled all around the state. Our grant covered 21 counties in South Carolina. So, you know, it was a lot of Midlands, PD, low country area. So, you know, I saw a lot of the state. We did classes everywhere. So it could have been at a school, a Head Start, a library, community center. We did stuff with lots of different groups, Autism Academy, Commission for the Blind, mental health. So literally, if there was like a building and a group, we could make it happen. And we did nutrition classes, we did healthy cooking. A lot of fun opportunities came up with it. I got to do some media work. So I've been on lots of the local news stations in Columbia, Watch Fox, WIS, ABC, just doing little cooking segments and nutrition demos and things. One of the big focuses with our program, along with doing that direct education and teaching all ages and all these locations, was we started doing PSE work, so policy, system, and environmental changes. So that was one of the other additions to that job the last few years that I was there. And I also got to do some really fun things with the media. I had a monthly radio gig that I did with Don Frierson in the urban scene. So I had a monthly nutrition segment. He let us on as a favor to a friend that also worked at the station for, it was March, National Nutrition Month, a year or so ago. And he was like, you ladies are actually kind of fun. So then he invited us back, and then eventually made us a regular. So we had a standing little segment on his show. And then I also, about a year or so ago, I got to do taped cooking segments with Marcus Lattimore, who you guys know is a huge celebrity in Columbia, the nicest guy. Had a lot of fun doing that. I was the only free person. Everybody, and even the kids were like child actors, so even they were getting paid. I was just there for fun and just soaking it all up. But that was really great too, and you can find them on YouTube. So that was fun. Got to do those tape segments. And so where I am now, I'm with Clemson University, and I just started in July. So it's been really fun, you know, starting a brand new job and moving cities in the middle of a pandemic, as you can imagine. So I landed in Anderson, South Carolina. So that's where I am now after being in Columbia for 13 years. My job is fantastic. It's a little bit of everything. I'm a professor for undergrads for one class, but the bulk of my job right now is doing food insecurity work. So we're working on food access maps and different survey projects tied in with food insecurity. And I'm also, because I am a dietitian, they're going to utilize me in their mobile clinics that they have. So if you didn't know, Clemson has mobile clinics and vans that go out into these rural parts of South Carolina and deliver, you know, different services. So they're hoping I can pull in the nutrition piece. And they're launching a new clinic in Walhalla, which is Oconee County, which is up here in the upstate. And so that's going to be another part of my job. So it's super fun. I'm really enjoying it, and I'm excited to be here. This is a great topic. So thank you, everybody.
Thank you. I think you hit your time there. Perfect. Very good. So next, can we get a little introduction from Nancy?
Good morning. I'm Nancy Lintner. I am a board certified clinical nurse specialist, and I am certified in advanced diabetes management. I graduated from nursing school a long time ago at the University of Louisville in 1981. I've been doing, my expertise is diabetes and pregnancy. I've been doing that from 2005 to 2016. I worked at the University of Cincinnati for maternal fetal medicine for 8 years as a program coordinator for diabetes and pregnancy. Have had a tremendous amount of fun working for the chair of the department. I did consults for maternal fetal medicine. I managed their insulin, their insulin pumps, their oral agents, looking at blood sugars every day, adjusting to keep that fetus safe and prevent that baby from getting too large. We also got recognized through the American Association of Diabetes Educators. We did some writing, we did some book chapters. I got to co-author the diabetes and pregnancy chapter in the Manual of Obstetrics. Currently now I'm working as a diabetes education specialist because I could not find the niche in Charlotte, North Carolina. So I work managing glucomander, helping physicians and nurses, keeping those blood sugars under control. Very, very difficult seeing a lot of COVID patients, and when the patients get COVID, their blood sugars become extremely high. When we do counseling on the acute side, there's a lot of nutrition that we talk about. I have found that many patients do not understand about how to manage their nutrition. It's a very fun piece of trying to help the patient with their diabetes self-management. I have done a poster at the American Association of Diabetes Educators Conference, not this past year, but the year before, on preconception counseling. I helped write the how to use an insulin pen at Novant Health, where I currently work. And then we also helped do a piece on, self-management once the patient gets home from the hospital, the survival skills. And then volunteered with JDRF this past January, doing how to take care of yourself as a woman from the teenage years through menopause, with Dr. Edith Miller, who is a renowned endocrinologist here at Atrium Health, which is one of our competitor hospitals. I think I've told you enough about myself. I want to hear more about you guys.
Oh, thanks. Okay, so now, thank you very much. Now, Olivia, please give an introduction.
Hi, so I'm Olivia. I consider myself to still be a fairly new dietitian. I've been working a little under 5 years in dietetics. I started working right out of school. I went to Winthrop University for my undergraduate, graduate, and internship program. But right out of school, I started working in long-term care and worked there for a bit and enjoyed it, but I was kind of looking for a little bit of a different population. So after that, I began working here at Student Health Services at the University of South Carolina. I started here about 4 years ago in the role of outreach dietitian. So I had a really fun job teaching cooking classes, being at the farmers market with like education and other presentations and programming for more of like the prevention side. But about 2 years ago, I stepped into the role of clinical dietitian. So now I see students one-on-one for any number of appointments. Our appointments are free, so that's a great resource to students. The majority of my population, as you can imagine, is age 18 to 24. And the things that I see most often are actually disordered eating. So I would say probably like 60 to 70% of my patient load is disordered eating, but I do also see things like diabetes, prediabetes, hypertension, high cholesterol, food allergies, celiac disease, and other GI disorders. So it's been fun working here at the university, so I'm glad to be here.
Thank you. And Dr. Cook, give a brief introduction.
Sure. Hello, everyone. My name is Jim Cook. I was OB-GYN by trade. The Natural Health Service Corps put my way through medical school, so I had to do a fulfillment of that by working in Indian Health Service. I did this time in Phoenix, at the Phoenix Indian Medical Center. And the reason I bring that up is for those are diabetologists in the group. I mean, if you want to work with diabetes, the Salt River Pima Indians were right next door. And so I provided OB care to a group that had a very high rate of diabetes for sure. From there, I came to University of South Carolina, where I've been involved with medical student teaching and residency teaching. I've always had interest in nutrition and obesity. And so I took some additional work and became board certified in obesity medicine as well. So I'm the founding director of the WOW Clinic, or the Women's Weight Management and Lifestyle Clinic at our office. It actually got shut down due to COVID, but we hope once COVID's over, we're back up and running again. And then also I'm heavily involved with prenatal care here. I'm the medical director for the clinic. And so one of my roles in that avenue is overseeing the centering, certain centering sessions. And for people who don't know what centering is, it's a trademark name for group prenatal care. And so we get real focused on nutrition in those sessions because we have our time for just education. And that's how group prenatal care differs from individual care, is you have more time for teaching. And so this group prenatal care model has really good outcomes. And so that's why we adapted it as well. I'm looking forward to hearing about everyone else. Thanks.
Great, thank you. So now we'll open the chat box for questions. So I'm going to be monitoring the chat. So if you have a question, you can type it in there or you can ask yourself. But we'll go ahead and start with a couple of questions. I have one for Kristin. What are some of the challenges that you face in relation to convincing the athletes you work with to follow healthy nutrition guidelines for both health and performance?
I think the biggest thing with working in sports is you have to build that relationship with them. You know, some of these kids come from a background where they don't have a whole lot of nutrition support, or they've had a coach or a personal trainer or strength coach who's told them about nutrition, and it's kind of building that relationship with them in order to show them of why nutrition is important, what your day needs to look like. I mean, something for us that's a little unique than other places is because we have recruiting and the recruiting phase, you start to get to know these kids, some of them 2 years before they even come here. So every time they come on a visit, it's meeting their parents, understanding their background. So it's really just building that relationship and understanding where they're coming from. But I do think one of the challenges is that even social media is a thing right now. That's, you see it on Instagram or you see it on social media, and that's a big thing. So.
Great. And then for Dr. Cook, what are some sources of bad nutrition information that you encounter from your patients? And then do you make any effort to try to teach them how to evaluate the source of nutrition information? And I guess that could be for any of our panelists and your clients, and kind of touched on by Kristin.
Sure. So I think a lot of times our patients come with information that either is passed down from their family or from social media or the popular press, you know, the cookie diet, the this, that, and the other. You know, I think one of the interesting things I had in my career when I first started is I had a lot of patients in the Indian Health Service who didn't want to take insulin because they were worried about it hurting the baby. And that was just the opposite of what I believed it was going to do, for reasons that Nancy outlined of improving fetal outcome. But, you know, I guess I didn't really think at that time that they were looking at this correlational effect, right? You know, their aunt or whatever had really bad diabetes, was on real high levels of insulin, and then had a bad outcome. So clearly it was the insulin that was the cause, and not what led her to need the high insulin. So once you have a better understanding of that, and then try to involve, you know, if you have a young patient who's bringing their mother with them or whatever to the exam, you know, trying to, why is it you don't believe in insulin? You know, where did that come from? What are the concerns? And then trying to address those specifically. Certainly there are times that I've provided literature or printed material to try to counteract widely dispersed lay writing. But I think one of the advantages you have as a clinician is as physicians, sometimes there is inherent belief in you because of your title. And so sometimes just taking that extra few minutes to say, you know, well, this is what my understanding of it is, and trying to break down those barriers is often useful. So that's how I try to tackle that problem, but it's very common.
Great. Any of our other panelists want to chime in? I'm sure you've all encountered some interesting information from your clients or patients, and then how do you try to steer them in a different direction or help them understand what's a good source or what's not a great source for nutrition information?
I can tell you we go through this all the time. I think after something like The Game Changers came out, and I don't know if anyone's watched that documentary, but that was something we had to definitely explain to a lot of student athletes why a vegan diet was not necessarily the right thing for them to do, and how challenging it can be, and getting them to really understand, like, why do you want to do what you're trying to do is always the thing of, what is the background? What have you heard? What is it that you saw Cam Newton did it and you think that's what you should do? Or, you know, it's those kind of things, is figuring out why do you want to do this, and what do you think? And then how do we tell them what they really need to do versus not do?
So I actually have some notes on that specific documentary, as I was going to comment on how documentaries are so influential, especially to the age group that we work with. That particular documentary, The Game Changers, it focuses on a vegan diet, which is, you know, not necessarily a bad thing, but not also for everyone, right? And one thing that I do bring up with my students a lot when they bring that to me is kind of look at the people that are, you know, creating this education for you. The producers of this documentary are James Cameron, who was the producer for the Terminator. Also, Arnold Schwarzenegger, we're familiar with him. Jackie Chan, also not really a medical or nutrition professional, and Pamela Anderson. So just thinking about that group of people, they all have a really, you know, important place in entertainment, but do they have that nutrition background to offer this advice to you?
And then I'd be really interested in Brooke's point of view on this, because you said you've been on both sides of this, right? You provided some media, and then you're also an educator. So I wonder how you deal with that and try to provide great information when you know that it's going to reach a wide lay audience.
Yeah, one of the things that like kind of originally I was thinking about was there was this period of time, probably like 7-8 years ago, when I was doing SNAP Ed, and Dr. Oz was huge. And it was like every single senior citizen in one of my classes was like, well, Dr. Oz said. I'm like, no. You know? And it kind of just makes me think of kind of what Olivia was just saying, you know, where you have these people that it's like, they're not necessarily, they've been portrayed, you know, to be the expert, but not necessarily. And I always just go back to the fact that I'm like, nutrition is a science. It is research based. So I always tell people like, this is not my personal bias. This is what the research shows us. And we always have to go with that. But people get, you know, caught up with, oh, this celebrity or this, you know, and me being in the media, I just try to, again, it's what does the research show? You know, that's my answer for people. This is what the research is showing us right now. Not that that can't change, you know, because it can, and that's happened, but just kind of letting them know that nutrition is a science, you know, and not everybody is the expert. So.
Right, and then I was wondering, then you touched on it, so then nutrition evolves and changes. So where do you all as practitioners get your information? Are there particular sources? And then how do you evaluate, you know, the strength of the research to pass on to your clients? Should we make Nancy talk? Oh, great. Here she
I think what we did, you know, we read the evidence-based research. We looked at the research projects that were done, landmark studies. We're always looking at landmark studies. We were looking at the ADA, the ADE for resources. We actually wrote all of our educational materials based off of evidence-based practice. You know, we were not printing things from the internet or buying things, because the maternal fetal medicine specialist, the chair, was very, very particular about tight blood sugar control. You know, and we looked at research studies from pregnant women that had worn continuous glucose sensors to see, you know, what the outcomes in terms of a big baby or whatever off of these research studies, because we wanted our patients to have great outcomes. Many of our patients would come in with A1Cs of 13, and what we did through a very short period of time, monitored the A1Cs, reported it to the AADE, you know, because we were certified. And many times we got those A1Cs down to 6, and we had very good outcomes. And I think the big thing that we did also is just try to cheerlead those patients, you know, meet them halfway, do motivational interviewing, and we found that that worked best in our program.
And then Kristin touched on this, and I have to imagine that Nancy and Jim have had these experiences as well, but more than just one person influences your clients' nutrition decisions. Kristin, you mentioned their families. Certainly partners of pregnant patients have ideas about what their pregnant partner should be eating, or, so how do you deal with these outside influences? And do you ever do co-counseling or education with your patient plus one?
We did, and we had a whole team working with our patients. We had community health workers, we had a diabetes case manager, we had a dietitian, we had advanced practice nurses, we had registered nurses, we had MAs, and we actually wrote a diabetes and pregnancy pocket guide for all healthcare professionals, which was very helpful, so that we were all speaking the same language. But we were family centered. We would love for, the mother of the patient to come in, or the sister, or the husband, and try to explain to them, how important nutrition was and the effects that it's going to have on their baby and their blood sugars. And then we combine that with, the importance of exercise as well.
Great.
I think
and
for the
response as well.
I'm sorry. For the weight management patients that I would see, often trying to incorporate the rest of the family into whatever changes they've been making is often essential, right? If everyone else is drinking soda at dinner and they're not, then it's going to be more challenging. And the reality is the suggestions that we're usually making are something that are probably applicable to everyone in their family. That no one really probably needs to have soda at the dinner table. And so the correlation between obese women and having obese children, is certainly high enough to warrant trying to do that. So beyond, trying to have this secondary effect of improving the outcome for the children and the other people in the household, it's just, it's more likely if they're not making steamed vegetables for themselves and then fried food for everyone else. I mean, it's not going to happen. So we do our best to get everyone.
Well, and the other thing, Abby, I think, a lot of the patients were not aware of portion control and how many carbohydrates they were eating, and how, when you're eating large volumes of carbohydrate, like 100 grams of carbohydrate, how are you going to take enough insulin to cover that? And, you really need to stick to those certain numbers of carbohydrates for your breakfast, lunch, and dinner, and then for your snacks or your bedtime snacks, and always combining that protein and carbohydrate so that the sugar isn't rushing so quickly into the bloodstream.
Fantastic. And then we had a question from the chat box as well. And this one is a question for pregnancy experts. So I guess Brooke will throw you in this one too, because you work with WIC a lot. Do you find that pregnant women, especially ones with obesity and diabetes, are interested in plant-based nutrition or diets, especially during pregnancy? And what is the state of the current evidence on that to support or not support that? And what resources are you using to counsel patients regarding plant-based diets during pregnancy?
I would say, just from my experience with WIC, and especially just being down south and where we are in the culture, it just is not a thing. Everybody's like, where are my meat and give me my sides to go with it. It's just like plant-based eating in that community, especially too, picture for WIC, a lot of times we had younger moms as well and first-time mothers, and some of them were teenage age, or early, college type age. I can't imagine somebody approaching me even in high school growing up in the South with a plant-based diet. I've been like, no way, where's my McDonald's? This is all pre-dietitian nutrition path, So, but you see patients all ages. I did have patients too with WIC that were in their 30s and 40s, and maybe sometimes they might have been a little bit more receptive. I mean, there for sure, we know there's research and evidence that there's benefits, to more plant-based eating, and a lot of people are doing more. I've heard like the flexitarian type term, where it's got that flexible vegetarian lifestyle, where maybe occasionally they eat some meat. So, I mean, there's definitely benefits, but I just didn't find with my population with WIC that they were very receptive to that. I'm curious of what Dr. Cook might see with his practice.
I'm so sorry, I had to step out for 1 second for a patient. Can you remind me what that last question was?
So the question was, do you have pregnant women, particularly with obesity or diabetes, who are interested in making a change to a plant-based diet? If so, what evidence do you use to inform how you're counseling them? Or is it also not a thing in the South, as Brooke was saying?
I don't really see it in the pregnant patients per se, but in some of the obesity patients, I do see it some. There's the Forks Over Knives documentary that is on Netflix that some patients have watched. If they're interested and willing to do it, I think the evidence resides behind a whole food plant-based, that they're, people can keep it up. That's also something you want to have the whole family involved with it. So I do see people, there is some interest in it. Usually it's a unique patient population that's coming to an obesity-centric clinic. Most 98% of people who could qualify for seeing a provider in weight management don't. So what is it about this 2% that comes? It's one or two things. Either their obesity's gotten to such a point where their BMI is 65 or 70, and it's really affecting all the confounders, and there's life is halted by this. And the real struggle we have with that is that other than surgery, it's hard to make drastic changes with BMI of 20 or something. So that I find in my practice, at least, that's very difficult to do. And so what the issue I always run into with our residents and other practitioners is, if you ask the patient, are they, is this patient obese? They say no because the BMI is less than 50. And that this idea of catching the people, and I know this isn't really answering your question. I guess I've gone off tilt here, but to me, I think interaction, being seen by nutritionists, by providers, learning that before you get to the real high BMIs can be useful. But better prevent it than try to take it away. But to answer your question specifically about plant-based diets, whether it's a whole food plant-based or not, it's not the most common diet that people want to follow, but I do have some people who have done it and had some success.
Great. So I kind of want to jump on something that you said there about your residents. So you're educating patients, and Nancy too, you're educating new physician workforce. So what nutrition challenges you see? And I'm not sure what the nutrition curriculum is in medical school or nursing. My impression is that it's a bit minimal. So how do you educate yourself and educate the next generation of the physician and nurse workforce?
I think what we have done is gather the residents and the maternal fetal medicine fellows together. And then we had a very experienced registered dietitian. She had her master's degree from the University of Cincinnati, and she also was a certified diabetes educator. She was brilliant. And then she would hold a session every time the new residents or maternal fetal medicine specialist fellows would come in, and she would sit down and she would explain, the meal planning. And we used very much what Lois Jovanovich used. If any of you know Lois Jovanovich, she was very, very strict with her patients. And then they also had the pocket guide, which had the information on how the patient should be following the meal and snack plan and how to control their sugars. We tried to teach the patients, and the whole team, to try to stay away from processed food, because the processed food really drives those blood sugars high. And we didn't have trouble with our pregnant women with diabetes. They were very, very motivated to have a healthy pregnancy and a healthy delivery. They wanted a healthy baby. And we had buy-in from our patients. So we felt very blessed.
So I can speak a little bit about medical education from, it's called undergraduate medical education with their medical school, and graduate medical education when they're residents or above. So for the graduate medical education, our residents, similar to what Nancy talked about, do have case symposiums and stuff where things are talked about. In addition, they rotate with me in the WOW clinic. And so I think our OBGYN residents get actually far more exposure than most programs of similar size do. And that's only because I had an interest in it. It wasn't a specifically designed sort of thing. And so as far as the undergraduate, the medical students, there are modules and stuff that are assigned, and hopefully they pick it up clinically by, a patient seen and they're referred to a dietitian or whatnot. But I can also tell you that, we have developed a CBL, a case-based learning series that has to deal with obesity and pregnancy and what effect does bariatric surgery have on pregnancy and nutrition and supplementation and stuff involved with that. And also, I think the university, at least the University of South Carolina here in Columbia, recently started a health system science course within the last 6 months or so. And things that are addressed in that are, I know that Brooke was talking about food insecurity. We had a local expert in food insecurity come and sort of speak to what the local scene looks like for our students as well. So lots of social determinants of health are, the whole fall semester of the first year is really social determinants of health, is where food security fell for us in the planning of that course. And so there is something that I don't love, some that they do a biochemistry class on the Krebs cycle, and that's considered part of their nutritional, and I don't, yes, it's a good background, but here and there. But anyway, there is a conscious effort to try to get some education in there.
That's reassuring. And then I have another question. This one comes from the chat box for Kristin and Olivia. How do you handle patients and athletes who disregard your nutrition advice? And so you might see, and I imagine both of you have repeated contacts with patients and they're not following what you're asking them to do. So what are your strategies there?
I can go ahead and start. I think mine's a little more unique because these student athletes are with me for anywhere for 3 to 5 years. So it's kind of like when you try a new food, you continue, it may take up to 13 times before you like it. For me, it's kind of learning about them and, getting them exposed to things like our cooking demos. One of my football players had never touched ground beef. And that was something for him, if you can cook it and you see how easy it is, you're more willing to try it. A lot of them have grown up where they've gotten snacks from the corner store and they are huge on those kind of things because some of those were their meals, right? So it's getting them used to food, getting them to try new things, but it's also when they see the benefits from it. One thing we do a lot of is hydration testing and, showing a guy how this relates to soft tissue injuries or if you had someone that was about to cramp at halftime and you get them to take an electrolyte packet and then they score a touchdown after that, they're hooked, right? So it's finding that thing that gets them, oh, I actually feel really good that I hydrate better. One of them was in my office yesterday and was like, Kristin, I really didn't used to take nutrition or hydration serious, but now I do and I feel so much better. Okay, so those are things that it's just, you repeatedly try to tell them it's going to be beneficial for them, but they also get to spend 3 to 5 years with me, so I don't give up.
I often see clients over and over. I don't quite see them for 3 to 5 years time, generally for 2 to 3 months at most. But a lot of challenges that I face with my population is that they're students. They seek, knowledge and education, and so you may have noticed nutrition information is everywhere. It's on social media, it's on advertisements, it's available through a bunch of different websites. And so when they bring me things or, question my advice, it's like, well, let's talk about what you want to work on, what you want to do, and then try to research that topic together, looking at things that we all look at when we're looking at good research studies. Does it have a good population size? Was there a placebo group? How, do you think that this is really applicable to you? All these different types of things are something that I bring up with this population. And then on the flip side of the spectrum, I have a lot of patients that disregard my advice because they have more of a disordered way of thinking about nutrition. And so that's such a different side of the spectrum to address, because it's not that they don't think that my advice is true. They just don't think that my advice is true for them, or that the fear of gaining weight is a big thing that I talk about a lot. And so a lot of my messaging is around health at every size, which is generally the idea that as long as you're, working on these health promoting behaviors, that your weight is not, a determinant of your health. And so this is a really hard topic to buy into, because we live in a very thin as health focused world. And sometimes it's just repeating the message over and over and over and over, that your body wants to be a particular size and you're still healthy at that size, even though that doesn't feel like what is most important to you at this time. So a lot of repetitive messaging as well for our population.
I would even piggyback off of Olivia. I think I go through some of the same things with our at-risk athletes, and it's finding what is important to them to make a change. One of my eating disorder patients, she doesn't have a period, but having kids one day is really important to her. So understanding how important it is to gain the weight in order to make sure that down the line, but it takes time to build that relationship for someone to explain something to you that really, then you have a leverage in it, right? We need to do this in order to do this. So it's kind of just learning, but I do think also with Olivia, a lot of this generation compares themselves to each other and who they're around or what they see on social media. So it's breaking it and giving them the confidence to be you and who you are and what you need to do to be healthy and happy. So.
And then to jump on that with you, Kristin, so you see athletes for 3 to 5 years, and then most of them don't go pro. So how do you transition them to now you need to have a healthy diet for you, or how do you transition them to being
Yes.
eating friendly?
Yep. So I actually was a college athlete, and we actually had a class about this, but I think this is a big thing for me is it's not just about performance. That's why we do things like the cooking demos and understanding about foods. I always tell them this is a lifetime commitment. So they always know they can always reach back out, but it's giving them the tools while they're here to know what healthy eating needs to look like and what a balanced diet needs to look like. Obviously, when they're seniors, even just for the female athletes, just teaching them of what you need to eat, when you need to eat, kind of working on nutrition timing is something that you can focus on in college, but also it still helps you post-college. So yeah, we definitely talk about what that needs to look like, because I think a lot of people, especially your linemen, do struggle with weight after college.
Interesting. So we have another question from the chat box to the pregnancy experts. They're asking what is the state of current evidence on the completeness or lack thereof of plant-based diets, and are they considered restrictive or nutritionally incomplete generally or specifically during pregnancy? So is there a consensus from the OBGYN community on plant-based diets during pregnancy, of which you are aware?
I don't know what Nancy's experience was in Cincinnati. There's really not a consensus, and to be honest with you, there's just not many pregnant women who are interested in doing the plant-based diet, at least locally. The people I do see that are older, which is surprising because I would have thought that younger people would have been more interested in it, but we really don't see a lot of interest in it. There would be folate or B12 maybe supplementation, but you just don't really. I can't think of a patient that we've ever had, the pregnant patient who's been on. We've certainly had vegetarians, but as full as full vegans or whole food plant based, we just don't see it that much. Maybe that'll change, but. And I'm trying to think of, the American College of OBGYN comes out with practice bulletins every month. They update them and stuff. And I didn't specifically look, and Nancy, I'm sure you're familiar with those as well. I don't know of any updated evidence on that.
Our registered dietitian wrote a meal plan, and it was Monday through Friday for vegetarians, but we did not hand out any plant-based sample meal plans for pregnancy. And to my knowledge, this 8 years that I was there, I don't ever remember a patient requesting information for plant-based. So I'm not much help. I apologize.
That's okay. This is really interesting. The gap in literature is maybe something people in this conference could hope to fill.
One thing to add on to that, Abby, though, is that I work in the residency clinic, and so I'm supervising the residents. So this is, basically a lower socioeconomic status at-risk patient population.
Right.
I wonder if people who work in a private practice office with commercially insured patients would be having different experiences. But
yeah,
in our patient population, we just don't see it.
I think you may be onto something there. And so then a theme that has kept coming up is the influence of media. And so Brooke is our official media expert today. How did you distill your message for the media? Like, how did you come up with a message that was like a bite-sized message for the public, but that was also very true and accurate? So how did you craft your media messages?
I think the biggest thing is just, again, going back to the research and was the research show. And a lot of times too, with my media opportunities, there was, some sort of agenda. Maybe they wanted me to, it's Heart Health Month, and they want me to specifically focus on that. So a lot of times they maybe wanted me to cater it to a specific topic. And again, it's just looking to see what's out there. But also too, since I was with SNAP-Ed, I always kept our audience in mind. And because we were grant funded by USDA and the government, we always tie in the My Plate and balancing out your plate. So it's like there were certain things that, because I was working with SNAP-Ed in our grant, I had to do specific things just for guidelines for SNAP-Ed. But again, it's like, what's the research showing? I'm not just gonna, I'm not making this stuff up. This is not my personal opinion. This is what's out there.
And so we actually had a little bit of this come up in an earlier symposium session and then sometimes you may do something for print media, say, and you have a message that you're comfortable with that you share, and then it gets edited to something that you feel is perhaps less accurate. Or how do you, have you ever had situations, or how do you deal with that?
I think we've had situations where just even like internally with our job and getting things approved, we were, as SNAP-Ed, we were a group of dietitians and nutritionists, and it's like passing over our product to somebody, for approval through the chain. And when people want to make edits to the actual content, like not, sentence structure, punctuate, but the content, I'm like, when did you become the nutrition expert? I thought that was us. So I will always take ownership. Like, I own my credential in what I do, and I am the expert. And I don't want anybody in the media or in the art department trying to edit my message, the content. So I think sometimes you can come across that, because everybody's the expert, right? Everybody has watched Dr. Oz or gotten on social media, so you do encounter some of that for sure. So just combating that, I hold my ground. I'm like, no, this is what it should say. So
great.
Because I'm not going to give out the wrong message. Like, if that's not accurate and that's not correct, you're not going to put my name and my credentials behind it. No way.
Great. And then we have another question.
Can I say something? Many of our patients would come in, and like you had talked earlier, well, my mother said this, my father said this, or my sister said this, or whatever, or I've seen this on the internet. And what I had learned in graduate school, if you get on the internet and you want adequate, up-to-date, evidence-based practice information, let's say, for example, for diabetes and pregnancy, there has to be a stamp seal that says health on the net. Otherwise, the patient should not be using these websites to get information on how to take care of themselves with anything. The website should say health on the net. And that's something that we had learned in graduate school. So I know it's difficult to convince the patient, to stay off of the internet, but, if it's not a good website or a valid website, they really shouldn't be reading it.
Especially pregnant women. My N of 1, I never Googled more than when I was pregnant. So So we have another question from the chat box that says, how prevalent, and this is for everybody, so we can kind of go, maybe we'll start with Olivia with the general student population. How prevalent is dietary supplement use in your population, and what are the current trends right now? And then how do you counsel in supplement use for people who are interested?
That's a great question. So there's kind of like the different categories of supplements that I think of when we're thinking about supplements. One is like your vitamins, minerals, things like that. And I feel like overall, generally utilization of that is pretty low among my population. If they are using them, I generally, especially if it's like, oh, I take a B vitamin complex or I take something like that, I generally ask, was that prescribed by a doctor? And generally the answer is no, which leads to a discussion on why you think you need these nutrients. But on the flip side of things, supplements such as like protein supplements, creatine powders, those are probably the most common ones that I talk about, although I hear of a few different like pre-workout type supplements pretty often. And so I have to really stay up to date on these products, but something I generally tell them to look out for is the FDA doesn't always approve all of these products. And so if you can find any with FDA approval, that's going to be your best source. But just being, really aware of how this product affects your body after you use it, like really tune into the way that you're feeling. Because a lot of the like pre-workout type supplements contain caffeine, which may feel helpful when you're doing exercise. But if you're looking at like the patient's heart rate and stuff, it may not be at a healthy level because of the added caffeine. I feel like Kristin could have a lot more to say on like nutrition supplements on that side of things, but generally I would say low. One thing that I have noticed a lot of is the hair, skin, and nails gummies that people like shill on Instagram have become really popular, and they're just I think a B vitamin complex with some collagen, and so they're not harmful in my opinion, but really popular right now.
Interesting.
Yeah.
And Kristin, can you chime in?
Yeah, so dietary supplements and supplements in general are pretty highly things that people use in athletics, obviously. Kind of the biggest thing for us is we very much stress the message, come to your dietitian or your athletic trainer if you really want to take something. Then also navigating through, one thing for us is, especially the athletic population, is if it's NSF certified for sport. Those are the only ones that we will allow them to take because they are third-party tested and we know what's in them is actually in them, but they're the gold standard for us. But another thing behind that is trying to understand why somebody wants to take what they're taking. Big things right now is collagen is a big one people use. The protein supplements, I always tell everyone, like, when you go to GNC, they're going to try to sell you whatever. They don't care if it's going to help you or hurt you. Don't trust people you don't know, but obviously GNC is not the place to go. But, just trying to talk to them about like, why do you need a vitamin D, or which vitamin D do you need? How often do you need to take it? Or what's your iron? Iron is a big one we use too, but the protein supplements is the biggest, and the pre-workout, the post-workout, the pre-workouts, I try to steer anyone and everyone away from those. Just because you just don't, if you don't know how to take it correctly and you're just taking it, you could really hurt yourself. So, I think social media is one of the most awful things for supplements. So it's just really understanding why people are doing so.
Can I pose a question to Dr. Cook? What are you currently doing with the B vitamins, the vitamin D? I think those are the two vitamins that I'm thinking of right now.
Sure, thanks, Nancy. So as far as vitamin B supplementation, we're really using it honestly if they have anemia, a macrocytic anemia that we think is B12 deficiency. We're not really using it for supplementation. The vitamin D is a more interesting question. Or locally, we've actually begun screening everyone for vitamin D, and then replacing it if they're low. And I'm not exactly sure what the percentage is, but it's somewhere 75 to 80% of African American women are vitamin D deficient, and so you take that, that's our general population. So we do certainly see that. We do vitamin D replacement, and then monitor and recheck if they're low. But not much for it to be.
Now, are you careful in the first trimester? The dietitian and I, we started tracking some of our type 1s, type 2s, and with obesity, and we had found that all of those patients were deficient. So did you start after the first trimester or before?
It's part of the prenatal labs.
Okay, gotcha.
So I don't believe we actually start the supplementation until outside the first trimester, but we are, a lot of women don't actually get to you to the 13, 14 weeks anyway, but it's a routine part of prenatal labs. And so we draw it on everyone.
And then what about fish oil? I saw some of the maternal fetal medicine specialists supplementing fish oil. What do you believe?
Generally, as a whole, it's not a routine recommendation out of our practice at this point. At least from a generalist standpoint, we're not routinely supplementing fish oil on a general blanket advice.
Thank you for sharing.
Sure.
I love it when the panelists ask panelists. That's like the blossoming of the conversation. And then Christine Blake wrote to everyone that she said, I've heard a few of you say, understand why people are doing things and meeting them where they are. And she comments that this seems essential for establishing trust. So I think that's maybe a nice spot to let people leave the conversation if they want. We're almost to the end of our hour. We have a few minutes left, but you are, I guess, officially released to your next obligation if needed. And then I don't know if the panelists want to stay on for a couple more minutes and see if anybody else has any more questions.
So. Can I make one comment?
Yes.
Okay. I think that that sometimes people assume that physicians are well educated in nutrition and are up to date on the most recent things. And I can tell you, if you're a general OBGYN, you're reading the Green Journal, which is put out by ACOG and whatnot, and there's kind of very minimal research in there. So I know that can put you in a different position, an awkward position, if you're suggesting something different than what the provider's saying. But just, I wouldn't be overly confident that your physician you're working with absolutely necessarily is as up to date as it could be.
Yeah, and then Kelly asked a question to build on that. What does it take in a medical environment in particular for nutrition guidance to become a routine recommendation? What is the bar in medicine? Is it scarily low? I don't know. Yeah. Because I think that is something that we think about, that there's not tons of nutrition counseling training for MDs or MDs to be. So I think what you said, Dr. Cook, was a great point, that perhaps, and especially when you think of medical school a while ago, there's, what is the continuing education that's required for physicians and nurses in nutrition? None?
If you wanted to have a position statement on whole food, plant-based diet and pregnancy, I mean, that would it's a monumental task, actually, because I feel like it would have to go through ACOG, and ACOG doesn't really do anything anymore without getting everyone else involved. So the Association of Women's Health Nurse Practitioners, the pediatricians, lay group people, they would have these, large organizations all come together, and they'd have to develop a position paper. And so it's, if anything, I feel like the process is so cumbersome that we probably don't have a position statement, because they want to make sure that if they put something in writing and put their stamp on it, that is incredibly well vetted and that it's completely based on the science. Because, and I get the point, if they rush to put something and then the science, isn't solid or something, then they lose credibility for other things. So I think, at least in obstetrics and gynecology, and I suspect other specialties as well, that the desire to not give false information makes it very difficult.
Okay, that's the last question I have from the chat box. So I think, thank you everyone for your time. What a great discussion. I really enjoyed getting to meet with everyone. So thanks, and have an excellent weekend.
Thank you. You too.
Thank you.
Bye.